Good afternoon, everybody. Thank you so much for joining us this afternoon for our latest webinar on the ACER laser from Celtic SMR Healthcare, and our last one of the year, of course. So we'll end on a high. I'm absolutely sure of that. So what have we got today? So we're looking at sports injuries today. I'm delighted to well, actually, before I go on. If you could all stay on mute, or one or two in the waiting room, let me make sure they come in. Those guys in. Let those guys join us. If you could stay on mute, please, that would be really appreciated. Any questions are welcome. We'll have a Q&A session at the end. Pop them on the chat box down here. If I can interject as we go along, I will. Otherwise, we'll always have time at the end to ask the questions. One or two joining us, so let me make sure they're in. There we go. So yeah, that's the housekeeping done. I'm Steve Sheldon from Celtic SMR Healthcare. For those of you who don't know me, lovely to see some familiar names and faces. Always great to see you join us again, and always nice to meet some new names and faces. So all very welcome. Who have we got today? We've got a really good lineup for you guys today. We've got some really good content coming. Welcoming back Salvatore. Ciao, Salvatore.
Ciao.
How are you?
I'm very fine, thank you.
Good.
Thanks.
We're looking forward to hearing from you again shortly. But a very warm, well, cold, but warm in another sense. Welcome from the UK. Thank you for joining us. And also, I'm delighted to say we have a ACER laser superstar, Jessica Livesey from the Foot Pod. Hi, Jessica.
Hi.
Okay.
Hello.
You okay there?
I'm fine, thank you. Yeah.
Good stuff. Great. Well, we're hearing you and seeing you loud and clear, so we'll be with you shortly again. Who else do I want to introduce? I would like to introduce, for those of you who don't know, but most of you will, Mr. Paul Siddy, ACER laser mega superstar.
Ciao.
Brilliant. Hiya, Paul. Good to see you as always. Paul, for those of you who don't know, is a regular contributor for ourselves. We're indebted to his knowledge and effort at Celtic SMR with regards to laser. And just turned up, I'm delighted to say, the fourth person we're going to hear from today is Patrick. I'm going to unmute you there, Patrick. You unmute.
Hello.
Good afternoon, Patrick. Well done for joining us. I know you've had childcare to take care of this morning, so thank you for getting to us. That's great. Brilliant. So we're going to hear a little bit from Patrick again in a short while, guys. Okay, so that's the lineup for today. So let's get going. Let's come to you, Salvatore. Over to you, my friend.
Can you see the presentation?
We can see. Yeah, everybody see that okay? Thumbs up?
Okay.
Thank you.
Perfect. Hello, everybody. My name is Salvatore Germano. I come from Pavia, that is a small city in the south of Milan, Italy. I'm a physiotherapist and consultant for ASA laser. Today we will focus our attention on sports and why use MLS, this kind of laser, multi-wave log system laser in sports application. Why? Because we want to offer to our athletes immediate results on sport injuries. For what? To reduce pain, hematoma, edema, swelling. We can treat muscle contractures. We can treat contusion and muscle sprain, tendon sprain. We can use it immediately after 24 hours after the trauma. We can treat ligament and tendon and all the inflammatory pathologies of the, I'd like to say, of the human body. In a second way, we can obtain fast recovery time and we have a long-lasting result. Why choose this kind of therapy? Because we have different kind of benefits. First of all, is a non-invasive therapy, is not painful, as the treatment is absolutely not toxic. We have a very anti-inflammatory effect immediately after the first treatment. We reduce the pain and the swelling. We obtain a faster recovery time. We are going to improve the range of motion of the joint that we are treating. We are also going to increase the strength, endurance, and the performance. We can use it to do a prevention of the other kind of injuries. We are going to increase the biostimulation of the tissues that we are treating. We are going to increase the activity, the life of the patient, and in particular, the patient needs less anti-inflammatory drugs during this kind of treatment. This is a very important slide because every time that we are treating a patient, and in this, today we will focus our attention in sport traumatologists, we have to know the specific clinical condition and the pathology that we are treating. Remember that if the patient is in very acute or acute pain, we have we are treating a very acute pathology or an acute pathology. We must use and set our device using low frequency and low intensity. Vice versa, if we are going to treat a patient with a subacute pathology or a chronic pathology, we have to increase the frequency and the intensity of our laser. Remember that we can select the CPW button to increase our admission of joule, and we can work with a wavelength, the 808, not in continuous interrupted, but in continuous to increase our energy. This is a patient of mine. He's a tennis player, so this is my patient. He's a male of 40 years old with a tendon sprain in tennis elbow. This is our image with ultrasound, where you can see with on the under the two red arrow, the black area that is the sprain on the tendon. How I've done the treatment? Remember that we have two ways to how to do the treatment. This is an example, so we can decide to do a treatment in scanning. And remember our philosophy, so don't focus the treatment only on the point of pain and only on the point in this patient on the point of sprain, but working all around the muscle, the joint, and the ligament that are directly connected with the pathology. We call this global approach, you know this, and so for this reason, I've done this different scanning following longitudinal and transversal scan with the small handpiece, covering more area possible with the light of the laser to increase what? The efficacy of our therapy. So I work on the overarm, I work on the arm, and we can also do a specific work, and I suggest to do it every time, on the optical window. What are the optical windows? Are that small area between one bone and the other bone that I must open to enter inside the joint with the light of the laser. Here I'm working on the lateral optical window, and here with a flexion of the overarm, I'm working on the posterolateral path every time in scanning, And immediately after, here, I'm going to work on the posterior medial path. So we have to know that the elbow has 3 specific optical windows. These are the optical window of the elbow. So every time, remember the global approach, the treatment on the point of the pathology, the specific point of pathology that we must treat, and the specific work also on the optical window to work inside the joint. This is another way how we can decide to work. Remember that we can set, and the software suggests us 2 different way of treatment. The first one is what you saw before. So we can treat in scanning, or we can treat steady point by point. The same, so remember the treatment in a global approach and the treatment, the specific treatment of on the optical window. I prefer every time this kind of treatment, because the software tells us how many joule I'm using for a specific point of treatment. Here I'm treating the first optical window. Here, with a flexion of the overarm, I'm treating the lateral path of the elbow. Remember every time also to use our handpiece in a perpendicular way, because in this way we can increase the absorption of the light of the laser, and we can decrease the reflection of the light of the laser. And this is our result. Consider that I've done only 8 treatments in a tendon sprain, and we have in 30 days the complete healing. How you can see in the second image, where we have the control with the ultrasound imaging. Also, my partner, that is a doctor, a radiologist doctor, he was not. He has a lot of difficulties to find also the scar. So this is for us a very, very great result, because we know that for the complete healing of the tendon is required also 1 year. Why we is important and we have obtained this kind also of result? Remember the photomechanical effect when we use the MLS laser therapy, and in particular with the photomechanical effect we have also increase of the production of collagen, and for this reason the scar that we will obtain is a scar that is more elastic respect another kind of scar and less fibrotic. This is a question for another kind of, also we can use in the elbow, but for other kind of joint. We can treat our patient only in static? No. Because we have different way to treat our patient, in particular when we have to treat an athlete. I suggest every time to start with the first approach, with the first approach where we can do, remember to apply every time the example of the normal physiotherapy, the activity of the physiotherapist, so we can treat in this way, for example, a tendinopathy on the Achilles tendon. We can do a treatment in dynamic passive. This is another kind of device, but we can do it with our handpiece of MLS. This is the Hero TT. So we can do a mobilization of the joint during our treatment to increase the range of motion. But we can ask to our patient to do an active movement when we do our therapy, for example, to increase the strength of the calf. And the last one is the more difficult, because is in a proprioceptive way, and we can do our treatment while the patient is doing the normal exercises in a session of physiotherapy. In this way, I suggest this kind of approach when we have to treat athletes and sportsmen, in particular the last one. Okay. And finish.
Great.
Many thanks, Steve.
Many thanks to you. Grazie mille, Salvatore. my Italian's getting better by the week.
Yeah.
That was brilliant. Thank you ever so much for that insight. Some really good information and knowledge there. One or two questions have come in to me, and I will keep those for the end. So thank you. Okay. Stick around, please.
Yeah.
But really, really grateful to you. Thank you. So you like your sport, right?
Yeah.
I know you're a keen rower.
I was a rower, I was a triathlete, and now I am a worker and physiotherapist full time.
How's your rugby knowledge?
No, rugby, I'm not, no, I don't know. No.
No, so you're not familiar with rugby league?
No, I'm not familiar. I'm not familiar.
Right, that's my segue, because we're going to Wigan now. We're going to go and meet Jessica Livesey, the Foot Pod in Wigan. Where's Jessica? Hi,
I'm
Jessica.
Here.
There you go. So
Hi.
good to see you. Thank you ever so much. So we've got to educate Salvatore on the rules of rugby league.
Well, I'm a bit. You're a bit stuck with me because
the wrong person in Wigan to ask, right?
Yeah, I'm the wrong person in Wigan to ask. Brilliant. Ask me about baseball, Cuban baseball.
Cuban baseball. Okay, well we'll do that. Cuban baseball, brilliant. Well, yeah, we're getting all sorts. So, hi Jessica. Now everybody, Jessica was a little bit nervous about coming on here. She's been really, really busy for her preparation, but I've reassured her that she's amongst friends. So everybody wave and say hi to Jessica.
Hi everyone.
Jessica is a ACER laser superstar. Had the laser from ourselves over a year ago now. Been amazed with it, her words. Absolutely loves it, and just last month upgraded to the Ultra Head. So I'm going to ask you about that later on, but for now, let's hear a little bit about, you've got a case study for us, haven't you? I'll get
yes.
I'll get the slides up for you. If you'd like to, just bear with me a second. This is where it goes wrong, because we're relying on Steve to be technically. Can everybody see that slide? The Foot Pod Jessica Livesey slide. Can everybody see that? I've got the thumbs up from Paul, so I'm taking that as he's either winding up.
Yes.
Yeah, brilliant.
Good.
Okay, you can see that as well, Jessica?
Yes, I can see that, yeah.
There you go. Over to you. I'll move the slides as you'd like me to. Just order me about as you wish, but over to you.
I will do. Right, okay. Hi, everyone. Like Steve said, I'm Jessica. I live in Wigan. I'm from Cuba. Studied podiatry and graduated from Salford University in 2008. I'm just looking at my certificate now. I forgot. In 2008. Recently, 3 years ago, I left the NHS after 11 years and started working in my own clinic. So I got my own private clinic at the moment. So over a year ago, we purchased the laser, and it's just been amazing for our clinic. I just want to say thank you to Steve and everybody from Celtic for all the CPD and all the updates that they've been putting on for us, because it's been fantastic. And a big thank you to Paul as well for all his help. Right, okay, so quick, my case study is a 45-year-old nurse, no medical history, started running at the beginning of October and had an ankle, a lateral ankle sprain injury on the 28th of October. So this is the first picture on the 28th of the injury. So went to A&E and was diagnosed with a grade 3 sprain, ankle sprain, but also that she was diagnosed with a high, they thought that it was a high ankle sprain as well. So I could only fit her in on the 2nd of October. So on the 2nd of October, she came in, we did an assessment. Of course, it was easy to bring her in because she actually works with me. So she's one of the nurses in the practice here. So that's why this injury was a little bit easier to treat, because I had her on hand and she could come in wherever I wanted to come in, really. So on that day, on the 2nd of October, we did the first laser treatment, and let's have a look. So the VAS pain scale was 10 out of 10. Of course, when she came in, it was very, very painful, no mobility at all, a lot of swelling, a lot of bruising, like you can see on the picture there, and a lot of pain on the lateral, just on the lateral side, where you can see all the bruising there, behind the malleolar line and underneath the malleolar line as well. A little bit of pain on the medial side as well, just where underneath the medial malleolus. So after the first treatment, this picture was taken on the 3rd of November. So this was only after the first treatment. So the scan, so I scanned the whole of the leg, all of the foot. So we did the holistic, approach for all of the muscles, all of the tendons on the foot. And then I only had the one them. I didn't have the Charlie head them. So I only used the one for this patient. So, and I used the contusion on all of the points where she said that it was sore, and then the pain relief after. So this was on the 3rd of November. So after the 3rd of November, the VAS scale was 7 out of 10. So I could palpate the area, and she could stand me, to start mobilizing, just to see if, just to do my own assessment. So I did an assessment, and I wasn't convinced that there was a high ankle sprain, because when I compressed the tibia and the fibula, there were no pain anywhere up the leg at all. So after this treatment, the only pain what she had, that it was excruciating pain, it was just right on the tip of the lateral malleolus there, where you can see it's like a little spot. And I was a bit suspicious of that, and I really thought that there was a fracture there. So after that scan, that treatment on that day, I asked her if she could find out from the hospital, she can ring up and see if she could get the results from the x-ray again. Just a little tip about x-rays: they don't get hot reported on the day. So the clinician who is in A&E, they will look at the x-ray, but the x-ray will only get reported by the actual, what did you call it? From the x-ray department, I can't remember the name.
Radiologist?
Radiologist, that's it. See, I told you my English was gonna go out the window.
Not at all.
So it only gets hot reported by the radiologist, I think it's the day after or 24 hours after. So it's good if you are suspicious of something, of a fracture, just to ask the patient to ring up to find out the results. Or sometimes it get missed, a fracture was missed from the diagnosis. So she had a fibular fracture at this point. So after the treatment on the 3rd, the swelling reduction was fantastic, the hematoma, she had good movement on the ankle. So if we can go now, so she had, let me have a look, she had up to the 20th, up to the 3rd, she had, let's have a look, so 1, 2, 3, 4, 5, 6 treatments with the laser. So, no, sorry, this was on the 10th. She had 6 treatments with the laser on the 10th.
So you saw her pretty much every day from the 3rd to the 10th?
Yes, I saw her on the 2nd for the full week, every day, from the 2nd to the 6th of November. And then I saw her on the 10th, which is 6 treatment, and then the 12th and the 13th, and that was 8 treatment. And she was walking and full range of motion, and not using the boot what she got given by the hospital at this point. So yes, this is my case study.
So can I just just check? So during those 6 treatments between the 3rd and the 10th, did you say you were doing some mobilization during that treatment, or was that not possible?
No, that wasn't possible.
I wasn't sure.
No,
sure. Okay.
I only did starting, assessing the ankle, because I wasn't sure that it wasn't a high ankle sprain. So that's why I wanted to make sure that I got the right diagnosis so I could treat correctly. So yes, after this, this is the pictures of me treating on the 10th.
That's you in there somewhere, is it? Under all that PPE?
Somewhere, I know.
Yeah. Well done.
So just to say, it's been really, really good. I never treated an injury like this before, because as a podiatrist, I don't really have the means to treat so quick an injury like this without reducing the inflammation first and the pain. But I must say that is the results what I had for this case. It was amazing. Yeah. So, and long-lasting results as well, because she's walking, she's not pain, nothing. And we started doing, after the results on the 10th of November, we started doing some proprioception exercises, very, very gentle on the ankle. So we get, all that scar tissue and everything to heal up properly, and nothing to heal up overstretch as well, not tendons to heal up overstretch or damage.
Brilliant. Okay. Now that's great. Now, and I've got 1 or 2 questions, and I was going to ask Salvatore a couple of questions about it too, but I think what we'll do is we'll leave them to the end. So thank you ever so much. So grateful for you sharing that that case study. I know how busy you've been. I'm sure everybody watching can appreciate how busy times are at the moment, and all the extra PPE in between patients is really adding to the pressure. So and I know you've had a particularly busy morning. So thank you for agreeing to talk to us, and offering to talk to us, I should say.
You're welcome.
And finding the time in your busy schedule at the moment. So thank you very much. That was really, really interesting. I've got a couple of questions. I'm sure Salvatore can jump in with 1 or 2 questions too, but we'll come back to it. We'll come back to it if that's okay. So you relax now.
Thank you.
Well done. That was brilliant. Thank you.
Thank you.
Where are we going to go now?
Hello.
Hi, Patrick. How are you?
I'm very well, thank you. Can you hear me okay?
Yes, I can. Everybody else hear him okay? Thumbs up. So.
I'd just like to say, just very quickly, thank you so much to Salvatore. That was really fantastic to see what you've done. It's lovely to see you actually in action and to see how you're doing the kind of passive, active, and proprioceptive rehabilitation as well. So that was really nice to see. Thank you so much.
Many thanks.
And likewise, perfect. And likewise, Jessica, again, you know, great to see you just jumping in there and doing things really nicely. So it was a great pleasure. And hello, Valerie. Not sure if you're cleaning or what's going on there, but if you were waving, but yeah, wonderful.
Keep going while she's doing some CPD, which has got to be the way to do it. Brilliant. Seems to be the way of the world.
Great stuff. Great stuff. Great stuff.
Great, thanks, Patrick. That's kind of you. Thank you. And we're delighted that you can join us today. We're going to do something a little bit different now for everybody. I'm going to ask Patrick a few questions, and then we'll take it from there. So go on then, Patrick. Introduce yourself. Tell us who you are, where you're from.
So I'm Patrick. I'm an osteopath. Prior to that, I was a personal trainer, and I've worked as a strength and conditioning coach and doing all kinds of weird and wonderful things. I've worked with cricketers, rugby league, rugby union, American football, and Paralympians, and should have been off to Tokyo with a fencer this year, but that didn't quite come through. So I worked down in Oxford and I've just tried lots of different things. But what's interesting is I kind of got into this trying to care for a patient. She went off and had shockwave for tendinopathy. And she kind of came back to me and said, look, you know, this is, thanks for telling me about it, but this is really, really painful. And I don't really want to do it anymore. And she was a patient from London, had come to kind of see me through a recommendation, and I just felt like I'd really kind of failed her by sending her off to something and she's tough. She's a really, really tough person. For her to say, yeah, I don't really want to do this, thanks very much, it doesn't feel right, had kind of made me think, right, what's out there? So I did a little bit of research, and I saw that photobiomodulation was something that people that had recommendations in different things. And I can remember hearing something about it from 7 years ago or so. So I kind of had a bit of a look about and looked at different things. And because I'm a massive geek, went and had a look at the research to see what actually works. And that's what kind of brought me to Celtic and to Steve. And so we had a bit of a chat, and actually just over a long stretch of kind of having a yak and doing different things. He was very kind. He said, look, give it a go and see what happens. And so, so that's what I did. I had a go. I got stuck in. I, did it on myself, did it on any stray people walking past, and on a couple of patients. And it was a really, really interesting experience. Brilliant.
Good. I'm glad you did. So what results do you typically get from the MLS?
Well, so it's interesting. So I'd kind of come in and I thought, well, if it just gets tendinopathies better, then that's a win. And so I thought, well, that's really good. And it was great, actually, speaking to Paul. And of course, he was fantastic, saying, look, this is what I do. But also, I do this, that, the other. And I was kind of yakking on about 1,001 different things. And he was very patient, said, look, just get stuck into it and give it a go. So I think initially I worked a lot with, tendinopathies kind of, but then other people said, oh, well, I've got this, osteoarthritis, or I've got this, I've got that. And it was interesting because one patient would kind of refer another patient, would refer another patient. I said, oh, and again, because I'm always talking about what I'm doing. So people would say, oh, so for example, I was working with one gent that I've been working with, for years. He'd come in on and off when he forgot to do his exercises, play golf, and did something silly to himself. And he'd say, oh, well, how about my wife? She's got these ulcers on her leg. And I said, oh, well, is it diabetic? Is it non-diabetic? He said, it's non-diabetic. I said, well, I'll do some research and then let's have a go. So I never thought I'd get into, wound healing or anything like that, but they had some cracking results, absolutely cracking results. Yeah. But the big thing is the reduction in pain. So if I'm working with someone who's had chronic There's one lady with chronic knee injury, which is going on, 6 or 7 years, and one treatment made a dramatic difference to that, which then meant that she engaged with doing her rehab. And when she starts doing her rehab, guess what? Everything else gets better. Likewise, working with other, I suppose I've seen 2 or 3 kind of sprained ankles recently. Again, as soon as you get people out of pain, working with what they do and what they don't do, you can say, look, okay, let's start getting back into that. Let's get that proprioceptive system working much better, decrease that likelihood of any more injuries, and let's get you working a bit better. So instead of saying, right, my normal ankle protocol would be get someone in, 3 times that first week, 2 or 3 times that second week, depending on the grade of sprain, and then get them contrast bathing, 2 or 3 times every single day, which, you have to be pretty determined to do. And instead of that, what I found is actually with people, they haven't had to do as much of that, but they have had this massive pain reduction. They've been able to do more strengthening stuff. They've been able to do more proprioceptive work. And I think that's kind of decreased the likelihood of injury, and it's kind of sped things up quite significantly. So that pain reduction is fantastic, but just the other things, the osteoarthritis, the wound healing has made me think, well, hang on a second, it's not an adjunct to physiotherapy or to osteopathy or chiropractic or whatever it is. It's laser therapy, and actually that's made me think, oh, it's a very different thing. It's now working as laser therapy and as a sideline to what I'm doing as well. So that's been an interesting kind of mental change also.
Brilliant, thank you. I can see Paul nodding away there when you're talking about getting the mobilization in there, getting the rehab in there. I think that's let's get Paul jumping in on that. Paul, I saw you nodding away to that.
Right, I should be live. Am I live? Can you hear me?
Yeah.
You can hear me.
Just to interject quickly there, because that was really interesting from Patrick. I've still got a couple of questions for Patrick, but I saw you nodding away there on a couple of points that he was making there. So do you want to jump in?
Well, yeah, it's this very basic thing. I've always made it very clear to people when I speak to them about the laser, that I'm not an employee of Celtic. They use me because I'm talking about it as a clinician who uses it. I learnt, not at university, not in my 2 years rotations in the NHS. I learnt working with the military. That's what I learned. You learn so much because you see proper injuries. You see people who are really to be motivated, most of them, to actually get better. And we have the one phrase I always learn, that tissues will adapt, but they will only adapt to stresses you put them under, which means exercise, movement, everything is paramount. And what I've always said, primarily about this laser, the phenomenal thing that it does, yes, it starts the tissue repair, but it's the anti-inflammatory, analgesic effects which it has, which then gets the person in a position where they're able to do the stuff which they have to do. And I've always said this, no machine just on its own can actually do everything. Actually, having said that, Patrick also mentioned about the biostimulation fact. Actually, this is where this machine is just phenomenal, again, because with ulcers, with wounds, especially people with diabetic ulcers, they have these ulcers forever. They never get better. They've seen physio after physio after physio, up to the NHS, whatever it is. Nobody can actually sort out their ulcers. And then they come in and you start working very strictly about the area we have, the surrounding area. So we're providing a very even, repeatable scan on this, where we're supplying between 1 and 4 joules per square centimeter. And hey, guess what? These things heal up, which have never healed up before. And they think you're some kind of god, which,
well, we do too, so don't worry, that's quite normal.
It has this phenomenal effect. What it comes down to is getting people to do the stuff which they need to do, and kickstart that repair process by getting the huge raising the ATP into the cells, start the activity, but then reducing the inflammation, reducing the edema, and getting the pain, inhibiting the pain pathways. You do that, and then we can do anything. And literally, I mean it, we can do anything.
Brilliant. Okay, thank you, Paul. That's great. I'm going to come back to you in a second. Patrick, you still with me?
Yeah.
Good stuff. Great. So no, that was great. So it's really really great when we've got two guys like yourself really sharing your thoughts. It's so invaluable to everybody, I'm sure. So thank you. So so I've asked you what you typically get results on with the MLS. Have you got a particular case you might want to share with us? Doesn't have to be too.
Patrick, so there'll be hopefully something will pop up in a little while, which there's
you on the spot there, didn't I?
Yeah, that's great. No, that's no problem at all. I mean, so I suppose there's a couple of things which are kind of interesting. So we've talked about tendinopathy, we've talked about osteoarthritis, and those two are. I mean, so again, so the lady that came in with the leg ulcers. She was saying, oh, I was in the garden yesterday. I was trying to pick up these seeds with my thumbs, and I hadn't even looked at her hands, which is a terrible osteopath. But there we are. But her thumbs were like that. She was just having real problems doing stuff. I said, okay, well, look, let's just we've got a bit of time here. Let me just give a little bit of a zap. So we just did that, and again had some spectacular results. So it was great just to see how actually someone had come in, someone had come in for a back thing. I told him about what I was doing. His wife came in, we did something with her ulcer, which then led to something to her hands. And now she's referred lots of her friends again for osteo stuff. So I think that's really nice. But one of the things that, I see a lot of is really tight scalenes. And so, and I think it's probably something that we all see. It's to do with stress, it's to do with breathing patterns, etc., instability. And so trying to change that I actually find really difficult because it's about breathing patterns, it's about changing autonomics, sympathetic, parasympathetic nervous system, all that kind of stuff. But what's really great is sometimes just giving it a good old zap with the laser, they massively reduce. And so you're thinking, well, why is that happening? But it is this small level of actually we're changing what's happening with the pain sensation. Those areas are starting to calm down and say, actually, we don't have to be in protective spasm. So that's great. Again, likewise with the trigger points, I think something that Paul had said with, you sometimes wonder if you're a genius with your needling for your trigger pointing or what it is when you combine that with the trigger point modality. But that's actually been, again, another great learning that I've had. So I've done some great stuff with that. I think what's interesting, just to bring it to an interesting kind of case study, is how do we try and kind of tie it all up? So I suppose there's with a pro golfer that I work with who he's like Darren Anderton. He's always doing something to himself. So he did a lateral ankle sprain, went in, had it checked, and he was in bits when he came in 24 hours after the injury, hobbling on his girlfriend. We did a scan, did some direct work, then actually used some voodoo floss bands, did some mobility, and then some active, so going from passive to active with him, just gradually getting some work through there. And then, he was actually up and about and walking properly by the time he left. And that's, 35 minutes or so from walking in to walking out. It was incredible to see. So that kind of thing is, you see that, you think, wow, there's no other way I could have got that done. So that was pretty special.
Brilliant. Thank you. I know you've you've got a couple of videos that you've shared with me that we've popped onto YouTube, and I'll share them with everybody if that's okay on our usual platforms too. So thank you ever so much for that. I'm conscious of the time, and I've got some great questions coming in. So what I'm going to do is I'm going to ask Patrick, you stay with us. Jessica, if you're still in the room and could come off mute. Same with Paul and Salvatore. Yep. Hi. It's Paul and Salvatore, if you could be available to answer some questions for me. Now, what I need to point out, obviously, to people, if it's not obvious, is there are people here today in the audience that have the laser. So, there's going to be questions here that they're asking specifically about the laser, about the settings, which might not mean a lot to people that don't have the laser yet, hopefully. And of course, there are people on here that don't have the laser and are clearly interested in what it's all about, what we're doing. So we're going to jump around with these questions, but just wanted to highlight that some of the questions are specific to the machine itself. And a question straight away for yourself from Tim. Hi, Tim. I hope the trial is going well for you with not the trial. He's not in trouble, anybody. He's not on trial anywhere. He is trialing the laser. Sorry, Tim. So Tim, I hope the trial is going well for you and you're treating lots of people. But Jessica's asking, could you share the settings you used? Did you use the formatted, the presets, Jessica, or was there something specific you used that you could?
No, I only used the presets. So I did the scan. I always use the scan. I did the contusion and pain relief. That was the only settings I used. If I had the knowledge what I had today, I would have used the inflammation and hematoma as well. But at that time, I was, I was quite pretty new to treating the ankle sprains with the laser. So this is what I used, and it worked well. It could have been better, probably. But yeah, and after the 10th, I introduced the proprioception exercises and the mobilization after that.
Okay, brilliant, thank you. And actually, it's interesting what you say there, because as a salesperson, when I'm talking to people about the laser, I do something I say all the time is, the settings are very self-intuitive, very easy to use. But I think Paul will be the first to say, and I'm sure Salvatore would add, as you go along, you try different things. And in the new year, we've got some really exciting news. And if we've got time, I'll have another chat with Patrick in this session. But Patrick is going to be involved with us. Paul obviously is going to be involved with us, and my colleague Jenny, I think has disappeared. And working with ASA as well. We're going to be putting together some courses in the new year, and it's really about a little bit more about understanding how laser works. So what are you trying to achieve, and what will laser do for you, rather than it be, just rely on the self-intuitive buttons, if you will. So that's a really interesting point. So watch this space on that, guys. So those of you who got the laser, your knowledge is only going to improve next year, and that's what we're here to do, is to keep supporting you. And those of you that haven't got the laser yet, and you need to know a little bit more, then we will up the options available to you for you to learn that knowledge. So that's really, really interesting point. So thanks for the question there, Tim. Whilst you're trialing the laser, do not hesitate to ask any questions as you go along. I hope that was stressed to you previously, so please do. We've got a question from Sam Seal, who is an ASA laser superstar. And he actually asked, and you might have touched on this, Jessica, but did knowing that there was a fracture, did that change your treatment pathology settings? Did that change anything? Well,
I concentrated a lot more on the actual fracture side. So instead, because I was concentrating more on ligaments, so behind the malleolus and underneath the malleolus, but not on the actual malleolus, because it's just bone. There is actually nothing there on the tip there. So and then I started concentrating on there, but I didn't change the settings. I just used it on the chronic setting instead of the acute.
Alrighty, brilliant. Okay, Salvatore, anything you'd add to
that? Nothing to say, because I'd like to say only one thing, that when we have to treat an edema, and it was a very great result, because many compliments, because I'd like to say only this, that I suggest to work following the lymphatic system to increase the washout of the allogenic substances, and to increase the pumping of lymphatic system. So I suggest to work like a lymphatic manual massage. So begin our treatment from proximal to distal, and distal to proximal. Begin our treatment in this way from the cavo popliteus, and following the medial part of the leg, where we have the big safena and the lymphatic collector, and at the end do the treatment on the malleolus area and on the foot, and so proximal to distal, and at the end do another time a follow-up to decrease our pumping, because remember that laser has a photothermal and photomechanical effect. So in this way we can increase all the microvessel, and with the photomechanical effect we can increase the peristalsis of the lymphatic system. In this way we can increase the washout and we can increase the drainage of the edema.
Brilliant. Okay, thank you. Appreciate the input there, Salvatore. I've got some more questions. If I miss anyone's questions, flag up to me, guys. Don't do it deliberately. Sorry, I'm getting some nice comments coming in, but I'm just looking for the questions. Here's an interesting question. We can get stuck into this one. Salvatore, Paul, and maybe even my colleague Jenny help on this one. Hi, this is from, and apologies if I get the name wrong, Taibji. I hope I've got that wrong. I hope I've got it right. I normally get it wrong. I hope I got it.
Steve,
Taibji,
can I
just
quickly interrupt you? I'm just going to have to go now because I got a patient coming in now. Is that okay? Thank you, everybody. I'm sorry.
You're an absolute superstar for taking the time in this busy times. Thank you.
Bye, guys.
Ciao.
Ciao.
Take care.
Thank you.
Thank you. That
Thank
was great.
you.
That was great. Isn't that great? How busy she is. She's made that time for us. That's amazing. Taibji, I hope I've still got that right. Hi, does NM matter? Paul and Salvatore, I'm going to come to you guys. This is a nice juicy one to get into. Research varies from 600 nanometers to 900 plus. Is there a difference between actual laser and LED? Oh, there's an interesting question. Paul, over to you.
Well, yes, of course there is. LED, you might as well shine a torch at somebody. Is my microphone on?
Yes, we hear all of that.
When we're talking about the widths, there is the therapeutic window, which there's a little bit of variation on this, but it's probably really around about 780 nanometers up to about 980 nanometers, where all the research shows that what's happening is that the light, if it's coming in, is really just causing scatter going surface and not going any depth whatsoever. Once you get to that between 780 and 980 or 950, let's say, you suddenly go down and deep up to 5-6 centimeters deep, where you're getting the depth and the penetration. What's happening is there are some lasers which will be using 980 nanometers. Around about 940, 950, it's actually gone up to the surface again. That just causes scatter. And if these lasers are giving loads of power, all it does then is heat up the watery dermis and cause some, dermathermic damage. It will cook you. So what's happening is it's very important to have that therapeutic window and get the treatment occurring at that area. That's why, look, ASA have chosen 808 nanometers and 905 nanometers. They've obviously done an awful lot of research. I'm not the scientist, and they've worked out those are the best, but those are within the range. If they'd chosen 810, 805, 815, they'd probably had a similar sort of effect, but they've worked out at the University of Florence or wherever it is they've done it, those are the best ones, but those are in the therapeutic window where we are getting the depth, we are getting the results that we want. And what they've done is they've stuck the on the 808 nanometers, they've got the ATP creation, the anti-inflammatory proteins binding onto the ATP, and the reduction of edema through that wave. And the 905, which is super pulse, is then really inhibiting the pathways. All this is going deep. And what's happening then is you're getting these four effects working together because the multi-wave lock system It's all synchronized together. And what's happening is they are synergistically helping each other. So that is, yes, the yes is the answer, very simply. It is important to actually try and pick the area which will really work.
Wonderful, thank you. So I'm just replying to one or two questions. Salvatore, anything to add to that?
Yes, in these therapeutic windows, like Paul said, we have the lowest absorption of 3 kinds of chromophores that are the hemoglobin, the water, and the melanin. And so for this reason, we have the maximum penetration and the maximum absorption of the laser inside the tissues. For this reason, we can arrive at a penetration depth around 5 centimeters. And if we have another kind of wavelength, and also for this reason, the patient don't feel any kind of warm sensation during the treatment, because we have the lowest absorption of the water. And the other laser, when with I don't do the name of the other company, but the patient feel warm, and the physiotherapist or the doctor, while do the treatment, was not able to work steady on the point, because the patient feel a warm and hot sensation, and you can burn the patient. For this reason, with the other company, you have to move your handpiece very, very fast, and the patient in this way don't feel any kind of warm sensation. With our laser, we can work steady, and we can arrive for this kind two of wavelength 808 and 905 in a penetration depth around of 5 centimeters.
Brilliant. Thank you very much. I hope Tayeb, that, and I got the pronunciation right there, guys. I hope that answered that for you. Thank you very much for joining us, and thank you for the question. I had a question earlier on as well. I've got a couple more to get to. Where's Jenny's question gone? Okay, right, Jenny, thanks for the question. Would the laser be good for rheumatoid joint pain as well? Anyone want to jump in on that one?
Yeah,
it's slightly off topic, but it's a really good, fair question.
Yes, is the answer.
Good. Well, I'm glad you're aware of the time, Paul, and we need to move on. So yes,
but yes, very, very much so. And
you wouldn't be a very good politician. That was too simple.
As we, I should be a politician, shouldn't I?
You should be.
The other thing, as I explained last week, and Salvatore backed me up, where, you know, what I do is with rheumatoid patients, I actually use the magnetotherapy as well, followed by the laser, and you get, you know, just amazing results. But yes, definitely a huge benefit to patients, because this is, you're not going to make their rheumatoid arthritis better, but the big problem they've got, you've got to create a better life for them, and their pain is actually really destroying their lives. And so you reduce that with this, then again, more activity, more movement, which is the one thing they really need.
Brilliant. Okay, thank you. All righty, keep me. I'm conscious of the time, and I know one or two people have had to leave. We'll keep talking, but if until there's no one left to talk to. But no, we'll wrap up slowly. This has been brilliant. Thank you. I've got a couple of other questions I would like to get in, though. Another question from Tim. Are you still with us, Tim? Have you had to go? Tim? Yeah, Tim's still with us. Can I ask a general question about settings for chronic plantar heel pain, where there is an element of nerve impingement, example, Baxter's neuritis? Salvatore or Paul?
Is not easy, say, a general parameter for a specific pathology without any kind of evaluation of the patient. But I'd like to say that if the patient is in a chronic condition, I suggest to begin your treatment with a medium high frequency. So you can start from 1500 hertz to maximum, and you can increase it, and an intensity from 50-75%, and you can increase your intensity. Following also what the patient, which are the sensation of the patient after the first and the second therapy. So you can immediately after, in the third session, you can modify the parameter. Every time I prefer speak with the patient and I'd like to know what he feels after the first, the second session, to modify eventually the parameter, because remember that we can follow the parameter of the device, that they works in a very, very good way, but we can begin also to play with the device when we understand that every clinical condition we have to follow a certain parameter. So in very acute and acute pain, low frequency and low intensity, if the patient is in subacute and in chronic, we have to increase the frequency and intensity.
Brilliant, thank you. And I've got a question.
I'll just add with that.
Sorry.
Exactly what Salvatore said, but I would also try, because if you're talking about Baxter's neuritis or anything like that, try some mobilizations just to try and free up the tissues, because working with the laser and some hands-on therapy is just very, very effective.
Brilliant.
Every time, Paul. I agree with you, because every time we have to work with also with our hand during the therapy. In this way, we can increase the efficacy every time of every single session with laser therapy.
Yeah.
Brilliant, thank you. I've noticed a thumbs up from Tim now. I know within Tim's practice, mobilization is he's a big advocate of that. So big thumb up from Tim there. Thank you, Tim. Thanks for your input. I hope the scanner's going well for you too. But that's completely off topic. We won't go on to that. Okay, I was just about to say a question from Angela, I think. Did I have a question from Angela? Here's Angela. Angela is our latest ASA Laser superstar. She's actually receiving delivery anytime now, I hope. We think, or if not already arrived. Anyway, I know this is from Angela. I know this is more of an acute injury, but can the laser help with scar tissue?
Well, yeah.
Okay. Straight yes.
Yeah.
They're asking all the right questions today, these guys.
Again, get your biostimulation settings and work it on it regularly. And on the scar tissue, yes, we can actually soften their scars, make them much better. We're also just affecting the collagen. I mean, that is all type 3 collagen. We'll change it to type 1 collagen, make it more elastic. We can get the changes on here. We can get some vascularity back into that scar tissue where it is completely avascular. And yes is the answer.
Brilliant. We'll make sure you got all the information on that, Angela, and how to best use that. Just so people know that this isn't staged and we're getting all the right questions. We've got a question from Emily. Nice of you to join us, Emily. Emily's asking a question around randomized controlled trials on. And I've got to find the question now. Where's your question gone, Emily? It was about here we go. So what RCTs are there on laser and healing diabetic foot ulcers? What have we got out there, Salvatore? As I say,
yes, there are a lot of researches also on the ulcers, and you can find also, you can download them and are totally free on our website, asalaser.com. You can download without paying anything. And if you are interested to any other kind of specific study, I can send them to Steve. But yes, we have to know that in general, in specific for the diabetic wounds, we can treat this kind of wounds, and they suggest to use the biostimulation program. working with a specific parameter and a specific admission of joule from 1 to 4. In this range, in specific, when we use biosimulation program, we are going to use 2.9 joule. In this range, we have a correct biostimulation of the tissues that we are treating. Less than 1 joule are enough, more than 4 are too much, so we have a rebound effect. On the diabetic wounds, we can help the patient to a biostimulation, but we have to know that this is a systemic pathology, so the patient must follow the doctor when for the diabetic. We can help him for the specific wounds, but we can help him, but is not the only solution, the laser therapy.
Brilliant, thank you very much.
Just to jump in there for 2 seconds. I think one of the things that's quite important is to say that with the all the stuff that is on the ASA website is actually using this laser. Or pretty much all of it is using this laser, or ones which have come kind of similar to this. Whereas with a lot of other stuff that I found looking at other lasers is they'll just talk about photobiomodulation in general. What's nice is we actually know this is the right thing, which is, so if you get this piece of kit, this is the thing that it will do.
Brilliant, absolutely. No, that's a really good point. Thank you, Patrick.